Hi everybody, and welcome to our module on Cushing syndrome. Cushing syndrome is also known as hypercortisolism, and it is a clinical syndrome where there are excess effects of the hormone cortisol. Cortisol is a steroid hormone. This is its chemical structure here. These four rings are consistent with a steroid hormone, and it's sometimes referred to as a glucocorticoid, and cortisol gets its name because one of its effects is to raise serum glucose, and we'll talk more about this later. And cortisol is synthesized by the adrenal glands. So in patients with Cushing syndrome, there's usually some problem with the adrenal glands where they are overproducing the hormone cortisol. So before we can understand Cushing syndrome, we need to review cortisol, because if you understand how cortisol release is controlled and what the effects of cortisol are, then it's very easy to understand Cushing syndrome. So we'll begin by talking about the pituitary adrenal axis, which is what controls cortisol secretion. So the hypothalamus releases a hormone called CRH, which is corticotropin releasing hormone, and that hormone acts on the pituitary gland, which releases ACTH, which is adrenocorticotropic hormone, and this hormone travels to the adrenal gland where it stimulates the gland to produce glucocorticoids like cortisol. Cortisol then has negative feedback on the pituitary gland and the hypothalamus, and so this entire system is called the pituitary adrenal axis, and that's what controls the amount of cortisol in our plasma. So in order to understand Cushing syndrome, you need to understand the effects on different organ systems of excess cortisol in the body, and I've listed all of the major effects of excess cortisol on this slide, and in the next few slides we'll go through each of these effects and talk about exactly what they mean, because if you understand these things, the effects of excess cortisol, then it's very easy to understand Cushing syndrome. Cortisol has a number of immunosuppressive effects, especially when the levels of cortisol effects in the body are excessive, like in patients with Cushing syndrome. Cortisol reduces the number of T and B cells in the plasma. It does this by sequestering lymphocytes in the spleen and in the lymph nodes. It also impairs the ability of neutrophils to fight disease. It does this by blocking the migration of neutrophils out of the bloodstream into tissue beds. Now, one caveat to be aware of in terms of cortisol effects is that cortisol increases the peripheral neutrophil count, and when you give patients cortisol-like drugs, their white blood cell count will go up. But even though the white blood cell count is up because there are more neutrophils in the bloodstream, the total body is immunosuppressed, and that's because all those neutrophils cannot migrate out of the bloodstream and enter tissues. In mast cells, cortisol blocks histamine release. It also reduces the eosinophil counts. And so because of all these immunosuppressive effects of cortisol, that is the basis for corticosteroids, which are cortisol-like drugs, which are commonly used as immunosuppressive therapy. So corticosteroid drugs are sometimes called steroids or glucocorticoids, but they're all drugs that have a chemical structure that resembles the structure of cortisol. So all of the drugs listed on this slide are used in the treatment of disease for their immunosuppressive properties, and you can see that they all have a chemical structure very similar to cortisol, and therefore they exert cortisol-type effects on the immune system and suppress immune system activity. As I mentioned earlier, cortisol is called a glucocorticoid because it raises the serum glucose. It does this through a number of effects on the plasma glucose. One of these is that it increases the rate of gluconeogenesis in the liver, so the liver produces more glucose. It also causes cells to become resistant to insulin so that they don't take up as much glucose as they normally would. And so through a combination of these effects, cortisol leads to increases in the serum glucose concentration. So as we'll talk about later, in patients who have Cushing syndrome and cortisol excess, they often develop hyperglycemia. They can develop new onset diabetes, and if patients already have diabetes, it can become worse when patients have cortisol excess. Cortisol is important for maintaining a normal blood pressure. It modifies the vascular smooth muscle tone to maintain blood pressure in the body. So what this means clinically is that when patients have excess cortisol, like among patients with Cushing syndrome, those patients develop hypertension. In contrast, when patients have adrenal insufficiency and low levels of cortisol, those patients develop hypotension. Cortisol also has a couple of effects on lipids. So it activates lipolysis in adipocytes, and what this means is that those cells will release some of their stored lipids, and therefore cortisol can increase the total cholesterol and triglyceride level. It also stimulates growth of adipocytes, and so for this reason, patients with excess cortisol develop fat deposition, and there are a couple of classic locations where the fat develops. One of these is the face. Patients who have hypercortisolism develop what's known as a moon face. This is a picture of what it looks like on the screen here. They also develop fat deposition around their trunk, and they can also develop fat deposition in the upper back. This is sometimes referred to as a buffalo hump. These are all classic locations for fat deposition when patients have cortisol excess. Cortisol also has effects on muscle, skin, and bone. Excess cortisol levels can lead to muscle atrophy, and so weakness can be a feature of hypercortisolism. Patients can also develop thin arms and legs, so even though their trunk and their face may become larger from fat deposition, their arms and legs can become very thin. Another classic feature of excess cortisol is thin skin that's prone to easy bruising. And in the abdomen, because of the fat deposition, the skin can become stretched and develop striae, which are also called stretch marks. They're shown in this picture here. Basically, the fat deposition stretches the skin, and then because it's thin, you can see blood vessels underneath the skin, and that's what leads to these red stretch marks. And then high cortisol levels are very bad for your bones. Patients with hypercortisolism can develop osteopenia and osteoporosis, and that's because cortisol inhibits osteoblasts, which lay down new bone matrix. And then in the reproductive system, cortisol suppresses GnRH release from the hypothalamus, and this leads to decreased release of luteinizing hormone and follicle stimulating hormone from the pituitary gland. So in patients who have hypercortisolism, they will develop hypogonadotropic hypogonadism. This means that they have low levels of gonadotropes, which are LH and FSH. So in women, this can lead to irregular menses or amenorrhea. In men, this can lead to low testosterone and low sperm counts. So if you understand everything I just went through in the last few slides, then it's very easy to understand the clinical features of Cushing syndrome, which is caused by cortisol excess. So patients with Cushing syndrome gain weight because of fat deposition. They develop hypertension and hyperglycemia and potentially diabetes. Their face becomes round. Women can develop menstrual irregularities. The skin can become thin and prone to bruising, and in addition, the skin can develop striae. And all of these things, plus some of the other features of Cushing syndrome, are depicted in this image on the screen. All these things are very easy to understand if you can just remember the effects of the hormone cortisol. There are a couple of special clinical features of Cushing syndrome that are unrelated to high cortisol, so let's talk about those now. The first is skin hyperpigmentation, which is darkening of the skin. It basically looks like the patient has a suntan. This occurs in ACTH-dependent versions of Cushing syndrome. In other words, it occurs when the cause of Cushing syndrome is high ACTH, and that's because the skin changes are caused by high ACTH and not by high cortisol. When the ACTH level gets high, the body will also overproduce melanocyte-stimulating hormone, or MSH. These two hormones always go together. When ACTH is high, MSH will be high. And the high level of MSH will lead to skin changes, and that will lead to the darkening of the skin. You can also see skin hyperpigmentation in adrenal insufficiency. I talk about this in another video, but when there's loss of cortisol coming from the adrenal glands, that leads to high ACTH levels, and therefore you can also see hyperpigmentation of the skin. Another special clinical feature seen in only some cases of Cushing syndrome is androgen excess. This occurs in some adrenal carcinomas where the carcinoma secretes cortisol causing Cushing syndrome, but also secretes androgens. The excess androgens can cause acne, and in women this can lead to hirsutism. And so acne and hirsutism are features of a minority of cases of Cushing syndrome. They only occur when excess androgens are produced along with cortisol. The most common cause of Cushing syndrome is exogenous glucocorticoids. You will see this very commonly on your clinical rotations. Usually it's due to patients taking oral prednisone. Many patients take this drug for its immunosuppressive effects. There are lots of indications. And so in patients who take prednisone every day, over time they will develop Cushing syndrome. This is not because their adrenal gland is overproducing cortisol. It's because they're taking high dosages of exogenous glucocorticoids, which have cortisol effects. When the cause is not exogenous glucocorticoids, Cushing syndrome can occur because of overproduction of ACTH by the pituitary gland. This is called Cushing's disease. We only call Cushing syndrome Cushing's disease if the cause is high ACTH from the pituitary gland. You also can develop Cushing syndrome if there's ectopic ACTH from a tumor. We'll talk more about this later. And then you can develop Cushing syndrome if there's an adrenal adenoma that is producing cortisol. You can break down the causes of Cushing syndrome into those that depend on ACTH and those that are ACTH independent. In the ACTH dependent causes, the ACTH level is high, and that stimulates the adrenal gland, leading to hypercortisolism. This is what happens in Cushing's disease and also when there's an ectopic ACTH syndrome like ACTH production by a tumor. In ACTH independent causes of Cushing syndrome, the ACTH level is low. And this is what you see when there's an adrenal adenoma. The adenoma is overproducing cortisol, and the pituitary gland responds by lowering the ACTH level, but that doesn't resolve the overproduction of cortisol because there's an independently functioning adenoma. So in the workup for a patient with new onset Cushing syndrome, the first step is always to exclude exogenous glucocorticoids by taking a history and looking at the medications that the patient takes every day. This is far and away the most common cause, and so the first step is always to exclude this cause. Once you've excluded exogenous glucocorticoids, the next step is to make a diagnosis of hypercortisolism. It would be great if you could simply measure the plasma cortisol level, but unfortunately it's not that easy. The reason this is the case is because our cortisol levels go up and down during the day in a rhythm. They are highest in the morning and lowest at night. So options for diagnosing hypercortisolism include one of a number of tests. The first is to do a 24-hour urinary cortisol excretion test, which requires the patient to collect their urine for 24 hours. Another option is to get a late-night sample of saliva from the patient. The cortisol level should be low late at night, and so if this level is elevated, that suggests hypercortisolism. You also can do a late-night serum cortisol measurement. And then the fourth option is called the low-dose dexamethasone suppression test, and I'll explain what this is on the next slide. And so what's usually done in clinical practice is, if you really think someone has Cushing syndrome, you often do two of these tests, and that's because there can be false negatives. And so if your suspicion is high, you want to pick two of these tests, do them both, and you want them both to be negative before you truly decide the patient does not have Cushing syndrome. And then finally, step 3, after you've made the diagnosis of hypercortisolism, is to measure the plasma ACTH level. This will help you determine whether the patient has ACTH dependent or independent Cushing syndrome. Let's talk about the low-dose dexamethasone suppression test. This is a screening test that can be used to identify hypercortisolism. This involves administering a low dose of dexamethasone, usually 1 milligram, to the patient at bedtime. Dexamethasone is a glucocorticoid and it has cortisol effects, so it will provide negative feedback to the pituitary gland, and it should suppress the normal pituitary ACTH release. For this reason, when you give the drug at bedtime, if you then do a morning blood test the next morning, the cortisol level should be low. It should be suppressed by the low dose of dexamethasone, and that's because dexamethasone has inhibited ACTH release from the pituitary gland. If, however, the patient has Cushing syndrome due to any cause, the cortisol in the morning will be high. Remember, cortisol levels are normally highest in the morning, and they will be high as they should be after a low dose of dexamethasone if the patient has Cushing syndrome. This happens because ACTH production is not suppressed from pituitary adenomas or ectopic tumors by a low dose of dexamethasone. So if the patient has one of these things causing Cushing syndrome, they will continue to produce ACTH even after administration of a low dose of dexamethasone. Alternatively, if the patient has an adrenal adenoma causing Cushing syndrome, cortisol production will continue and not be suppressed, and that's because adrenal adenomas are independently functioning and they don't modify their production of cortisol when you suppress ACTH release from the pituitary gland. Once you've done one or more of those screening tests we mentioned 2 slides ago, and you've diagnosed the patient with hypercortisolism, the next step is to measure the plasma ACTH level. If there is a low plasma ACTH concentration, this indicates an ACTH independent cause of hypercortisolism, and this suggests an adrenal tumor, and so the next best test is usually a CT scan of the adrenal glands to look for a tumor. If, however, the ACTH level is normal or high, this suggests an ACTH dependent cause of Cushing syndrome. This usually indicates either a pituitary tumor that's producing ACTH or ectopic ACTH production from some other tumor in the body. Once you've got this finding, the next step is to determine the source of ACTH production. And there are a couple of ways this can be done. One is through the high-dose dexamethasone suppression test. Other options are the CRH stimulation test and petrosal vein sampling. One of the ways you can identify the source of ACTH production is through the high-dose dexamethasone test. This involves administering a dose of dexamethasone at bedtime just like in the low-dose test, but you use a higher dose, usually 8 milligrams at bedtime. The idea here is that the higher dose will differentiate causes of high ACTH Cushing syndrome. If the patient has a pituitary adenoma producing ACTH, then the high dose of dexamethasone will suppress cortisol when you measure it the morning after a bedtime dose. That's because pituitary adenomas, even though they don't suppress their ACTH production to a low dose of dexamethasone, they do respond to a higher dose. In contrast, if the patient has an ACTH producing tumor like a lung tumor, then cortisol will not be suppressed even after a high dose of dexamethasone, and that's because these tumors do not respond to either a low dose or a high dose of dexamethasone. And so I've summarized these things in this table at the bottom of the screen. When you administer a low dose of dexamethasone, that will suppress cortisol production in a normal patient, but it won't suppress cortisol production in patients with adenomas or ACTH producing tumors. When you administer a high dose, that also suppresses cortisol in normal patients. In addition, it suppresses cortisol in patients with pituitary adenomas, but it does not suppress cortisol if patients have an ACTH producing tumor. An alternative way to determine the source of ACTH production is through the CRH stimulation test. This involves administering an intravenous form of corticotropin-releasing hormone, the hormone that normally comes from the hypothalamus and stimulates the pituitary gland to produce ACTH. If the patient has a pituitary tumor, then the ACTH level and the cortisol level will increase after intravenous CRH administration. That's because in these patients, pituitary cells are actively synthesizing ACTH, and their release of ACTH can be boosted by a surge of intravenous CRH. If, however, the patient has an ectopic tumor like a lung tumor producing ACTH, then there will be no response to intravenous CRH administration. That's because in these situations, the pituitary cells are not synthesizing ACTH. In fact, they've become inactive because all the ACTH in the body is coming from the ectopic tumor. So when you administer CRH and shortly thereafter measure the level of ACTH and cortisol, you see minimal or no response to that surge in CRH that you've administered. A final way you can determine the source of ACTH production, which is only done in special cases where the diagnosis is unclear, is called petrosal venous sampling. So the petrosal venous sinus drains the pituitary gland, and you can take a venous blood sample from the petrosal venous sinus using a catheter. You then can measure the ACTH and determine the gradient, meaning the difference between the central ACTH level obtained from a venous sinus sample and the peripheral ACTH level measured from a standard blood draw. If the patient has a pituitary ACTH source, then there will be a high central to peripheral ACTH gradient, meaning the level of ACTH is much higher in the petrosal vein compared to peripheral veins. This slide shows an algorithm from the White Coat Companion that summarizes the workup we've been talking about for patients who present with clinical features of Cushing syndrome who do not have an exogenous source of glucocorticoids. So like we talked about, you begin by picking one or two tests to identify hypercortisolism. If the patient does not have hypercortisolism, then the patient has an alternative diagnosis from Cushing syndrome. If, however, the tests for hypercortisolism are positive, then the next step is to measure the ACTH. If it's low, then the source of hypercortisolism is the adrenal glands, and so the next step is adrenal imaging, like an adrenal CT or MRI, to look for a tumor or hyperplasia. If, on the other hand, the ACTH level is high, then the patient has ACTH-dependent Cushing syndrome, and the next step is to figure out where the ACTH is coming from. This can involve a pituitary MRI to look for an adenoma. It can also involve the tests we talked about earlier, like the CRH stimulation test, a high-dose dexamethasone test, or petrosal venous sampling. And then if this testing is positive for a pituitary source, then the patient has a pituitary adenoma. If this testing is negative for a pituitary source, then you have ectopic production of ACTH coming from a tumor elsewhere in the body. When patients have a pituitary tumor releasing ACTH causing Cushing syndrome, as I said before, this is called Cushing's disease. This is usually caused by benign pituitary adenomas, meaning they don't metastasize, but they do produce ACTH. Usually they're microadenomas, which are adenomas smaller than 10 millimeters in diameter. Sometimes they're even too small to identify by MRI, and that's why you do the testing we talked about in this video to confirm that the source of the ACTH is the pituitary gland. These can be treated with a specialized form of surgery called transphenytal surgery. The main complication is diabetes insipidus because when you remove the adenoma, you can damage the pituitary gland's ability to release antidiuretic hormone. Luckily, this is only rarely a permanent problem. And then if surgery is not possible or unsuccessful, radiation is also sometimes used to try and destroy the adenoma. When a patient has an ectopic tumor releasing ACTH causing Cushing syndrome, some of the tumors that can do this are listed on this slide. Small cell lung cancer is a classic cause of ectopic ACTH production leading to Cushing syndrome. Some other tumors that can release ACTH include carcinoid tumors of the lung, islet cell tumors of the pancreas. Rarely, medullary thyroid carcinoma can produce ACTH, and thymus gland tumors can also sometimes produce ACTH. The treatment in these cases is to identify the tumor and then perform surgical resection to take away the source of the ectopic ACTH. When patients have an adrenal adenoma causing Cushing syndrome, the treatment is often a unilateral adrenalectomy. You remove the adrenal gland on the affected side, and the remaining adrenal gland can perform the normal endocrine functions like producing glucocorticoids. When patients have refractory Cushing syndrome due to any cause, you can treat them with a bilateral adrenalectomy. If you remove both adrenal glands, no matter what the cause of Cushing syndrome, whether it's due to high ACTH or low ACTH, you will cure the patient of Cushing syndrome because you take away the adrenal glands so they can't produce excess cortisol. The downside is these patients now are missing their adrenal glands, so they require lifelong glucocorticoid and mineralocorticoid replacement. And then lastly, if patients have Cushing's disease where the pituitary gland is overproducing ACTH, there are some medical treatments that decrease ACTH release that can be used. These are usually reserved for cases where surgery is unsuccessful or not possible. One of these is cabergoline. It's a dopamine agonist. It can be used to treat hyperprolactinemia because it's a dopamine agonist, but it also suppresses pituitary ACTH release, and this can help in some patients with pituitary adenomas. The other option is pasireotide. It's a somatostatin analog, and it can block the release of ACTH. And that concludes our module on Cushing syndrome.